All right. Good morning, everybody. Happy Friday. Thanks for logging on for this week's AMSSM Sports Ultrasound case series presentation. So today we're just going to jump right into this. We've got Dr. Brian Sutterer, who's one of the Mayo Clinic fellows up in Minnesota, who's going to be giving a talk today on a case of retrocalc bursopathy. So for the sake of time, Brian, I'll just pass it over to you and you can get rolling.
Great. Thank you very much. All right. So before we get started, I just want to, of course, give a quick thank you to Dr. Sellen and Betcher, who have been my kind of primary mentors this year and, ultrasound teachers, and have certainly forgotten more than I feel like I'll ever learn. So thank you to both of them for helping out with this case. As Dr. Cruz mentioned, I'm fellow up in Rochester. So Dave, one of my colleagues, I think presented a few weeks ago, and I'm down in Rochester. So pleasure to be here and present this case. So the objectives for this morning are to, first of all, just review the scanning protocol for the ultrasound evaluation of the posterior ankle, sort of in the context of a case of retrocalcaneal bursitis. Along the way, we'll review the anatomy of the posterior ankle relevant to said ultrasound images, talk about some normal and pathologic ultrasound findings, and then work on composing a diagnostic report. So our case was a 47-year-old recreational runner who had around 2 years of posterior heel pain. There was no associated trauma. Her pain was worse with weight bearing, running, and the contact pressure from her shoes. She had some swelling over kind of the posterolateral heel ankle area where she had the tenderness, and had tried a number of different treatments, including physical therapy, some anti-inflammatories. She had been immobilized in a walking boot for a period of time, had tried a previous retrocalcaneal bursa corticosteroid injection, and had even undergone a previous percutaneous vacuum debridement with 10X device, and came to us because she was still having persistent symptoms despite these previous treatments. On her physical exam, she had some mild swelling kind of in that region of sort of the posterolateral heel where she was having her tenderness. She was tender on both sides, sort of just anterior to the Achilles tendon, just kind of cephalad to the top of the calcaneus, kind of right where you'd expect to see sort of the retrocalcaneal bursa living, more so on the lateral side compared to the medial side, but no real significant tenderness directly over the Achilles tendon, either the insertion or through the mid portion. She had a little bit of reduced dorsiflexion with her knee extended and straight, a little bit of discomfort kind of posterior to her lateral malleolus, kind of over the peroneal tendons, and then had some decreased eversion strength that was kind of secondary to some of the discomfort that she was having on palpation. These were her initial x-rays. You can see nothing too remarkable in the area other than a little bit of a Haglund deformity here in the calcaneus, which we'll talk about later on in the context of retrocalcaneal bursitis. Of course, a plantar spur here on the calcaneus, but otherwise, pretty normal looking x-rays. And so the posterior ankle ultrasound protocol kind of broke this down into the standard structures and then some things that would be optional just depending on each individual's specific presentation and what you found on your exam. So the standard structures: Plantaris, the Sural Nerve, Achilles tendon, Retro-Achilles Bursa, and then the Retrocalcaneal Bursa. And then optional things to consider, I think especially if somebody has a lot of sort of mid-portion Achilles tenderness, including the Gastroc Myotendinous Junction, as well as the gastrocnemius muscles, the soleus, the tibio-talar joint, posterior subtalar joint, some of the deep posterior leg musculature as relevant, and then the peroneal tendons. All of these just as you see fit based on your scan. One thing I will point out, it often comes up, what constitutes a complete scan versus a limited scan, and especially in an area like the posterior ankle where it might feel like there's really not all that much back there compared to something like the shoulder or the hip. If you look at code 76881 in terms of what requirements are needed for a complete scan, essentially one of the points is looking at the joint space in addition to kind of particular soft tissues, muscle, tendon, etc. And so really the inclusion of looking at the posterior subtalar joint, looking at the tibio-talar joint would technically meet criteria for what could be considered a complete scan if you include evaluating the underlying joint. So one thing to consider going forward with the protocol. Considerations for the scans: I think a lot of the scanning is going to be done with a mid or high frequency linear transducer. I think typically like to use the high frequency. Sometimes the larger footprint of the mid frequency is helpful just to see a bigger surface, area, a bigger range, especially if you're looking at a structure in long axis like the Achilles tendon. Sometimes that that extra, cephalad caudal distance is helpful with the mid-frequency probe. The small footprint, kind of high frequency, like our hockey stick transducer, can be very helpful for doing procedures in this area, and is also very helpful if you're having difficulty kind of following some of the structures around the malleoli. That smaller footprint can be just much easier to trace those contours. Curvilinear might be used if you're trying to get much deeper to look at the ankle joint or the subtalar joint. And then in terms of patient positioning, typically going to have the patient prone and then side lying with either the lateral or the medial side upwards, depending on if you're trying to look more at the medial and lateral structures. So starting off with the plantaris tendon, important to realize, of course, this can be congenitally absent in a number of people. And so if you don't see it, it's possible they just don't have one. This was the plantaris tendon in our patient, looked very normal. Of course, you're going to see this coursing kind of medial to the Achilles tendon. If you're uncertain, I think starting up in the popliteal fossa is one way that you can try to identify the structure. Of course, it's going to cross superficial to the popliteal vessels the majority of the time. And so if you want to look further proximal to try to identify it versus scanning more the Achilles tendon itself and looking for that tendon sitting kind of on the medial side. A couple of things that you might see, of course, you can have true plantaris tendinopathy. And so this was an individual, not our patient, but someone else. General theme here, blue boxes is our patient, red boxes are other cases. And so you can see a very thickened plantaris tendon. Also important to note, this can remain intact whenever somebody has an Achilles tendon rupture. And so here's an individual with an Achilles tendon rupture who you could see still had a very nice intact plantaris still spanning across that region. Next up is the sural nerve. I think the importance of really focusing on this structure if somebody has a lot of numbness or paresthesias over the lateral foot. Your Tinels can be helpful in terms of focusing really where you want to pay attention to the nerve, particular on your scan, because of course there can be a lot of variations in the anatomy. There's multiple different courses in terms of the lateral sural, the medial sural, kind of where everything connects together. And so using your Tinel sign to really focus on what area of the nerve to be looking at, and especially if somebody has those kind of paresthesias, foot numbness on the lateral side of their foot, paying special attention to the sural nerve. I apologize, not the greatest image quality here, but of course is going to be sitting kind of on the lateral side of the lower leg between the Achilles tendon and kind of the fibula. One case here, this was another individual who had some sural nerve compression after a direct trauma. And so one thing that can be helpful when you're looking at these nerves is to, kind of rotate long axis on them to see if you can find an actual point where there's some focal thickening. And so here you can see much thicker sural nerve compared to a more true normal caliber, which corresponded to the area of this patient's kind of focal compression injury. Next up, the Achilles tendon, of course, probably the most common thing you're going to be looking at in this area, and we certainly won't dive into a comprehensive Achilles tendon evaluation here, but I think understanding just when you're scanning this area, the difference between insertional versus mid portion and understanding all the different things that can come along with Achilles tendinopathy or Achilles tendinosis. It's not just a simple, straightforward, you have Achilles tendinopathy or you don't. There's a lot of other features that you can see on ultrasound that kind of extend beyond this lecture. I think certainly a dynamic scan is very important in the individuals who there's concern for an Achilles rupture, because number one, you can see if in fact there is, no conjugate motion, but then also how well the two ruptured ends come together, which can help in terms of ultimate non-operative success. And so this was our patient. There was maybe a little bit of deep-sided kind of partial tearing that we'll look at in some subsequent pictures, but otherwise no significant hyperemia. There was no real significant thickening of the Achilles tendon. Even despite having gone through a previous 10X procedure, the Achilles tendon looked for the most part fairly normal. She did have this sort of erosive change on the calcaneus that was appreciated and was well outside of her area of tenderness and had some inflammatory markers that were checked and were normal. So we thought this was just sort of an incidental finding. Just to briefly show some photos and mention, like I said, there can be a lot of variety with what you see in the Achilles tendon. This is another example of somebody who had a lot of insertional tendinopathy with sort of a prominent enthesophyte, lots of hyperemia in the area. You can see without the Doppler flow, that enthesophyte sitting there. This was another individual who had just mid-portion tendinopathy with some more focal kind of intrasubstance tearing that we could appreciate scanning in long axis, but really not that much in terms of hyperemia. And so just to kind of highlight when you're scanning this area for the Achilles, there's a lot more to think about and consider, which I'm sure will be the topic of other more focused lectures with Achilles cases. One of the optional things I mentioned, of course, is the Gastroc myotendinous junction. And I think one of the teaching points I've learned is, really focusing on this area. If somebody has more Achilles mid-portion pain, certainly if they have pain at that region between the gastroc and the Achilles, that myotendinous junction, this is an area that you're going to want to focus on. I think there are some really nice resources that I just wanted to highlight. This was an infographic from a BJSM article and great share on Twitter. It just shows some of the graphical kind of clip art representations of what we can see with these different types of injury. And there's some very good data out there in terms of recovery time based on the ultrasound findings in this area. And so know that if you're concerned about this area and going to scan it, there's some very good references out there to help guide, your evaluation, what to do in this location. We did not scan it in this patient just because her pain was so much more distal and kind of focal at that calcaneus. Next up on the list, the Retro-Achilles Bursa. I think the big thing to point out in this area is being very cautious about your transducer pressure. And so you can see here in our patient, you can appreciate this nice gel standoff, because even the slightest bit of transducer pressure can actually cause enough compression to occlude those neovessels. And so you might get a false sense of assurance that there's no significant hyperemia there. If you're really kind of losing track of what you're doing and you feel like a fellow and you're pushing way too hard on the back of the heel and you smush out all those vessels. So be aware of your transducer pressure. Of course, remembering to, the red here, this is going to be the Retro-Achilles Bursa. So retro behind the Achilles, if you're looking side on at somebody, as opposed to the Retrocalcaneal Bursa, which we'll get to next, which is going to be on the deep side of the Achilles tendon. These are a couple of other cases just showing what you can see in this area with true Retroacilles bursitis. Our individual patient did not have anything in that area, but this is an individual who clearly has a lot of thickening in that tissue with a significant amount of hyperemia with focal tenderness in that area as well. So getting now to the Retrocalcaneal Bursa, important to know off the bat that a small amount of fluid can be normal. And so if you're seeing an individual and they really don't have anything on their exam that raises a lot of concern for Retrocalcaneal bursitis or bursopathy, if you see a trace amount of fluid, that can be completely normal. I think what you're really looking for is a very large amount of anechoic fluid in this area. You may see varying degrees of hyperemia here, similar to what we can see with the Retroachilles Bursa. And typically this is going to correspond to the area of tenderness. And so I think this is a definite area of the body where your sonopalpation is extremely important in guiding what you're focusing on with your scan. And so if somebody has a lot of discomfort kind of right at where you expect the Retrocalcaneal Bursa, I'm going to have sort of a much lower threshold to consider what might be going on there, to look at the fluid. And so here, if I pause, some of these videos, you could see not really too much hyperemia in this area when we're just looking at sort of the straight long axis view on the back of the ankle, but clearly a fairly prominent, amount of fluid. I've certainly seen worse, but this would go beyond what we'd expect to see with a normal individual. When you're scanning this area in a short axis on the Achilles, of course, if you're going from the most caudal to cephalad, basically following the calcaneus, and then as soon as you drop off the calcaneus or you see the calcaneus go away, that's going to be where you'd expect to see the Retrocalcaneal Bursa live. Couple other examples here. This was our patient from a prior scan, so back before she actually had her initial treatments. And so you could see even at that time, there was quite a bit of fluid there in the Retrocalcaneal Bursa. This is another individual who had some Retrocalcaneal bursopathy, but had in addition quite a bit of deep-sided tearing of the Achilles tendon. And we'll talk on the next slide about kind of the true footprint of the Achilles. But you can see here just a little bit more extensive undersurface tearing of the Achilles than we saw in our individual. And so again, going back to that point that in this area, there can be a lot of kind of overlap with how these different pathologies can sort of go together. Going back to our patient, again, that point of sonopalpation, the majority of her tenderness was on the lateral side. And so when we looked really in that area, this kind of corresponded to her most focal point of tenderness. And so posterior on the left Achilles tendon here. And this was sort of the lateral protrusion of kind of that Haglund deformity that she had. And here you can see quite a bit more hyperemia and really that more prominent kind of bony change that is still going to be contributing somewhat to that Retrocalcaneal Bursa lying underneath. And just to quick call back to her x-rays where we can see that increased bone there with the Haglund. I mentioned important thing to consider with the true footprint of the Achilles. This was another good pearl from Dr. Selin and Betcher throughout the years. Trying not to confuse a large, deep-sided tear of the Achilles tendon with just absence of where the footprint, doesn't typically run. And so in this patient, this whole area of the calcaneus is really that Haglund deformity, and the true foot of the Achilles is further distal. And so if you're scanning one of these, if you're doing a retrocalcaneal injection and you start to see, some fluid kind of tracking down distal, it might be easy to think, oh goodness, there's this big deep-sided tear, but you have to be aware of what's really going on with the underlying bony anatomy, because in this case, there really wasn't any major tearing of the footprint. It was just that Haglund deformity is not anchored onto the Achilles tendon. And so there's this sort of natural space for the fluid to trace upwards. And so just understanding that the true footprint is really going to be more distal on the Achilles, and you don't want to confuse absence of the footprint for a partial sided tear. Calling back again, just the importance of the difference between a Haglund deformity versus an Enthesophyte when we're looking in this area. So of course the Haglund is going to be more on kind of that superior portion of the calcaneus, kind of sitting right here, more intimately associated with the Retrocalcaneal Bursa, versus Enthesophyte is going to be more at the insertion, kind of that distal portion of the Achilles, and typically more associated with Retro-Achilles Bursitis. Next up, looking at the peroneal tendons. Again, in this case, our patient had some tenderness in that area, and so typically this wouldn't be part of a standard kind of basic posterior ankle scan, but she had some discomfort, she had some difficulty activating, and so we decided to go ahead and scan the peroneal tendons. The important things to focus on in this area is, looking at, is something a pathologic split tear, or is this just incidental? Some interesting data, 50% of these seen on imaging are asymptomatic, and fairly high prevalence on some cadaveric studies. And so just be cautious when you're seeing evidence of split tears, especially in the peroneus brevis, and how that correlates to pain. Our patient did have a split tear, or kind of this longitudinal kind of anechoic defect, if I get a little bit clearer picture here, coming through her peroneus brevis, kind of right there. And, in her case, this really was not her limiting pain. She was kind of tender, a little bit more cephalad to this area where we kind of appreciated that tear. There was no significant tenosynovitis in the area. And so we thought this was more an incidental thing that was not truly her primary limiting pathology on her exam. Finally here, the posterior ankle joints. So again, this is kind of one of the things that might make the difference between whether or not you're considering this a limited scan or complete scan. Of course, using your best judgment in terms of the true utility and looking at this area. Typically, you're going to need to go deeper. So either using your mid-frequency linear with maybe a wide scan mode, or looking at the curvilinear transducer to appreciate here first the tibio-talar joint, then the posterior subtalar joint, looking for any effusion, looking for osteophytes in this area. You can do a dynamic plantar flexion maneuver to look and see if anybody's getting their typical pain reproduced for possible posterior impingement. So this is kind of the joint portion of the posterior scan. Moving on to our report now, I think this is important to highlight, this article by Dr. Hall that was published in JUM earlier this year, with some guidance and recommendations for documentation and just terminology for diagnostic ultrasound. And so I think it's important to try and get our reports to sort of match what's being recommended now. And so in this case, the basic identifying data at the top is to fill in, as you need to for yours. But our clinical history: 47-year-old female, 2 years of atraumatic posterior ankle pain, etc. In this case, because we had included the joints, this was considered a complete scan of the posterior right ankle, specifying that we used a mid and a high frequency linear transducer, and the patient was in a prone position. The findings, I know there's a lot of variety. I sort of like the approach of making it a little bit more narrative than just a list of, Achilles tendon normal, peroneal tendons normal. I like sort of the narrative flow, almost like I'm reading an MRI report to a degree. And so in this individual, there was a little bit of mild thickening of the Achilles and some possible kind of deep-sided tearing that we can go back and look at if anybody's interested, but primarily the associated retrocalcaneal bursal fluid and hyperemia, consistent with that retrocalcaneal bursitis. And then the majority of the rest of this report is basically specifying, the things that we otherwise would be looking for in this area. The rest of the structures being normal. We had some mention in here, of course, about the kind of incidental split tear that was noted in the peroneus brevis muscle. And then the remainder of the structures being normal. And then finally, the impression with the report, focusing on, what we felt like was the most prevalent number one thing, which in this patient's case was the retrocalcaneal bursitis, and then the remainder of our findings. I'll say one thing just to kind of consider when you're putting your reports together. I think the difference between if you are scanning a patient as a referral, almost more like a radiologist, versus if you're scanning your own patient, deciding how much of sort of that clinical context you want to put into your report. So in this case, this patient was somebody that we were clinically treating as well. And so we knew the clinical context well enough to say that this peroneus brevis split tear did not seem to be related to her current symptoms. I think if you're doing an ultrasound in this area as more of a referring scan for a different provider, I might be a little bit less conclusive on my call in terms of the impression and be a little bit more ambiguous to say something to the effect of, a linear kind of anechoic defect was appreciated in the peroneus brevis. Please correlate clinically with the patient's symptoms. And so trying to make that distinction between what you know of the clinical context and being more specific in your report versus maybe just being the referring ultrasonographer and sending that report back to somebody else who has the clinical context. So some final key points here. Remember that a small amount of fluid in the retrocalcaneal bursa can be normal. Don't confuse the normal Achilles footprint with deep-sided tears or defect. Be very cautious of transducer pressure and how that can influence the presence of hyperemia. And then use palpation, use muscle activation to really guide your additional exam in this specific area. And that is all I have.
All right, great job, Brian. Thanks for doing that. Yeah, that was great. You followed the exact kind of outline of the presentation that we wanted, and I thought your protocol was fantastic. So really great job. You kind of hit on most of the points I wanted to make because again, you did a great job. But I will make a couple points here, and then obviously Doug will have some comments, and Jake and Brennan, if either of you have anything, you can just certainly unmute yourself and just yell over me. This is one of the regions, like, we always talk about, I often will start with the joint. This is one of those spots, one of the very few spots where I don't. And I'd be curious to hear what Doug has to say in terms of how he starts these, but I'll start here with the Achilles tendon. That's always where I start. Then I'll look at Plantaris, and I'll look at Sural Nerve, then I'll look at, posterior ankle joint or posterior subtalar joint. And then I'll add in, medial lateral scans as, or structures as indicated, which I find myself often doing, with these folks with posterior hindfoot pain. I don't know, at least from what I have seen, rarely is it, fairly focal pain. It's oftentimes spills over into the lateral ankle, or it'll spill over into the medial ankle. And so I'll find myself, taking a look at the fibular tendons if they have, more lateral based pain, or looking, at posterior tib or any of the other flexor tendons on the medial ankle if they have more of medial ankle pain. So I think this is one of those regions that has quite a bit of crossover with other areas and other structures. So your point about that was well taken. I think, sometimes early on when we're teaching fellows how to find these structures, I've seen that sometimes fellows can have some difficulty finding the sural nerve, for various reasons. And one kind of North Star to help find that structure is to find the lesser saphenous vein, because those will always run next to each other. However, being mindful that if you have, any more than minimal transducer pressure, you're going to compress that and not be able to see it. But that is one structure to help you find sural nerve there. The other, I guess, last point to make, with retrocalc bursopathy, your point about physiologic fluid there is well taken, and I think important. And this, ties back into correlating sonographic findings with clinical history and clinical examination, and then as well as sonopalpatory pain. I certainly do see folks with an isolated retrocalc bursopathy, but I think, at least from what I've seen more often, this is more of a broader clinical presentation, meaning, we see somebody with retrocalc bursal fluid. We'll often see retrocalc bursal hypertrophy. We'll often see, some deep tearing of the Achilles insertion, and we'll often see, this prominence of the posterior superior calcaneus, which really, paints this picture of this Haglund's syndrome. And so I think taking all of those into consideration when you're again looking at the patient from the entire clinical picture rather than just your ultrasound is important there. So that's all I got. Yeah, Brian, that was really well done. Judy, do you have anything to say?
Thanks. Yeah, I'm Judy Pearson today. Brian, I just want to reiterate that was extremely well done, concise, and thorough. Yeah, going back to the protocol. So with my protocol, I have and this is really the same discussion that you can make with your protocol for, plantar hindfoot pain. And so my protocol, I actually specifically lay out what images I get of the Achilles. So I sort of divide up the distal Achilles from the mid portion of the Achilles, as you pointed out. And I also put just an extended field of view as part of our protocol. I find that really helpful just to see the big picture. So that's, one of the images in my protocol. Sural Nerve, Plantaris, as you have. And so another image in my protocol is soleus, and it's a long axis of the soleus, because a low-lying soleus can present as a mass. There's debate whether it influences pain in this area. And so even if my extended field of view shows a soleus, I'm fine, but looking at the distal soleus attachment is part of the protocol. And then I get a short axis of the medial tarsal tunnel. And I do this for two reasons. One is the protocol should be designed not only to be thorough evaluation of the area, but also include a differential diagnosis of pain in that area. And so problems in the medial tarsal tunnel can give heel pain. And so just by I just do a quick sort of sweep, proximal to distal of the medial tarsal tunnel. If it's normal, then I just simply get a still image of a short axis. And now I've gotten pretty much everything you need for a complete. So I've gotten joint, you get nerve, you get vessels in that. And plus I'm looking at the differential diagnosis. So short axis of the medial tarsal tunnels in my Achilles and my plantar hindfoot protocol. Second point is, as you point out, the distal Achilles tendon pain or distal Achilles tendinosis or tendinopathy, however we want to term it, is heterogeneous. It's a group of, in a sense, abnormalities that we can see in variation with the, Retro-Achilles, the distal Achilles, the bone itself, whether Haglund's and Enthesophytes or intratendinous calcifications, the Retrocalcaneal Bursa, the tendon itself, and variable amounts of tearing at the insertion. And so it's heterogeneous. And so for those that do a lot of procedures in this area, we look pretty closely at the pattern that we see. And so is this mostly, in your case, I get the sense that you think that bony projection at the lateral insertion is potentially a pain generator. And that might be very different than when you see a large Haglund with a lot of partial undersurface tearing, and maybe you address that differently than if it's more isolated in the Retro-Achilles Bursa, for example. And so again, for those of us that do procedures in that area, we look very carefully at the pattern of the distal Achilles tendon to help direct how we might approach the treatment to that. I mean, if there's a high-grade tearing and a huge Haglund deformity, we may decide this is more of a surgical problem. And so just understanding that when it's a heterogeneous appearance to that, but when that pattern doesn't pan out, my radar goes up. So when I saw that erosion, my radar went up right away and saying, okay, well, is this something different? And I think you've shown pretty clearly that that was erosion, but probably not the problem, because you clearly outlined, where you thought the pain was. But I've had a number of cases where I think this is more of an enthesitis associated with the seronegative spondyloarthropathy. And in those cases, you know, all lab markers may be negative. And they clearly have a different pattern to it. We don't see the big thickening of the Retrocalcaneal Bursa, the Enthesophyte, you know, sort of the developing Haglund's deformity. So again, keep that in mind when you're looking at these. And if it doesn't follow these patterns that we see, your radar should go up. And along those lines, you know, I gotten away from injecting the retrocalcaneal bursa unless I am absolutely positive that this is an inflammatory disorder. And I've seen rheumatoid arthritis present as, you know, fairly acute synovitis of the retrocalcaneal bursa. And if you look at the undersurface of the Achilles and it's normal, then I think it's, you know, it's okay to inject that. But when we see this type of pattern, you know, there's some early undersurface fraying, then I stay away from cortisone in this area. And then finally, the report. I think the report was good. I would argue and say that even in the clinical setting, your report still should stand alone. And so what I might encourage to say is, you know, there was no pain at the site with the peroneal tendon or minimal pain with sonal palpation, you know, clinical correlation. Or, you know, in this case, you could say from the Enthesophyte, you know, there was a prominence of the lateral Enthesophyte that corresponded to the maximal site of tenderness with sonal palpation. And so I think in any setting, radiology or non-radiology, that information is fair game and important. And it's also, you know, I think you listed out very clearly, and for those of us that do a lot of it, you know, that information, you know, is a stepwise approach to how we, you know, can understand what you're saying. I think it's also sometimes what I do is say distal Achilles tendinosis as described above. And I lay out in the body all those abnormalities, and then I just basically say distal Achilles tendinosis. So that's sometimes, you know, how I'll resolve all these little facets to, you know, the syndrome here. So discussion regarding that. Jake or Brendan, I mean, you guys see a lot of these. Anything to add?
Hey, Doug, can I ask you a quick question?
Yeah.
So you mentioned, you know, looking for a low-lying soleus. I'm just curious if you have any, you know, objective way to identify a soleus as low-lying versus not.
I don't. You know, usually the soleus, I mean, gosh, I'm sure there's probably studies out there looking at the average, you know, distance of attachment. But when the soleus goes right up to the retrocalcaneal bursa, that is a low-lying soleus, and I've seen that. And some people will even call it an accessory soleus when it goes right up to there. So no, I guess for me, it's more qualitative, but I just make sure I look at that it's not going right up to the retrocalcaneal bursa.
Great, thanks. Yeah, just curious. And yeah, I think the other thing to mention is there's, you know, a lot of accessory tendons that can be seen down in this area, quite a few. And so just knowing and being aware of some of those accessory tendons can be really helpful. You know, for example, we had a patient who ruptured their Achilles, and we actually just published this not too long ago, but it had essentially an accessory lateral gastroc tendon without an accessory head. And so there's all these different types of, you know, anomalous tendons down in that area. So being mindful of that can help in some of these patients.
Mm-hmm.
All right. Yeah.
Jacob.
Hey guys, just wanted to chime in real quick. First of all, Brian, fantastic job. I thought you really hit all the important points there, and some great comments from Ryan and Doug. I think the comment about this being a heterogeneous disorder is really key, because as we're understanding more and we're having more treatments available to us, I think this really becomes a very tailored type of treatment plan that you put together, rather than, I think in the past, people thought of insertional Achilles as sort of a cookie cutter type approach. So great. I would just say one other quick pearl that I think has been mentioned at this conference, but I think is important when you're looking at the Achilles is to just, we a lot of times put the Achilles in dorsiflexion to try to make the fibers taut and get better imaging of the tendon, but just to be aware, especially for the fellows, that that can decrease your vascularity in the tendon if you're trying to pick that up on Doppler. But great job, everybody. Thanks.
Thank you, everyone.
Thanks, Jake. All right, great. We'll call it here. Brian, again, that was really well done. So thanks for doing that. Great job. So as is normal, we're off for a week. We'll be back on the 17th, I believe. Yes, the 17th. So Ryan Nussbaum, who's out at UPMC, is going to be presenting a case on proximal adductor magnus tendinopathy. So hip case there. Otherwise, everybody have a good Friday. Have a great, safe weekend, and we'll see you soon. Thanks, Brian.